Thank you so much for inviting me. And I still think and tell the experience and the pleasure I had coming down to Port-au-Prince and doing surgeries with you. And I look forward when that will be something that's possible again. So I was asked today to talk a little bit about total hips and total knees. So I'm going to give a very basic discussion, more thinking of what's available. When I was down in Port-au-Prince, we did hemiarthroplasties for a kind of a subacute chronic hip fractures, cemented partial hip replacements. So we'll review that a little bit because I think that's a very powerful tool for these patients. So I'm Rand Schwarzkopf. I'm from NYU in New York, and it's again my pleasure to be here. So when we're doing a total hip replacement or a hemiarthroplasty, there's different approaches. There's the direct anterior approach. There is the Watson-Jones. There is the lateral approach, and there's the posterior approach. I think the most versatile and the one that's most easily extensible is either doing the modified lateral, if you're comfortable with that, or doing the posterior approach, which is also a trauma approach, which many surgeons may be comfortable from doing acetabular and pelvic trauma. So the important thing is, as we get into it, is how we position our components, and then what bearing surfaces and fixation. It more depends what you have available for you from implants. So we need to think about what are the complications that can happen to us. The hips can dislocate. So first thing you have to be aware of that, and you have to know how to relocate a hip. But when you have less resources, I think you really want to try and avoid dislocation, and we'll talk about those options. Wound healing and infection. These surgeries have implants, so they're prone to infection. When you're in ideal conditions, infection rates are below 0.5%, but infection can happen. So ways to avoid that we'll discuss, and then getting the patients out of bed quickly and avoiding fractures while doing the hip replacements. That's more easily done when using cement. The rate of fractures are very, very low. So if you look at all the differences between the stuff we talked about, there's not much differences in the different approaches and how you do things. Each one has some benefits and side effects. So as we said, risk of dislocation, it really depends on the patients and the approaches. When doing a hemiarthroplasty, you're maximizing the femoral head size because you're putting an anatomical head size, so risk of dislocations is lower. We'll talk about making sure you have leg length and offset because those will decrease the risk of dislocation. But again, you don't want to over lengthen a patient and have them have now a long leg after the surgery. They will be uncomfortable. When patients dislocate, what's important is to relocate them sooner rather than later. It's not an emergency that has to be done within the hour, but should not let patients stay long with a dislocated hemiarthroplasty or total hip because they can put pressure on their sciatic nerve if it's a posterior dislocation. And if they're skinny or malnourished, especially with patients that had hip fractures, if they stay long, they're actually lying on that dislocated hip in the back, and they can cause skin erosions and wound complications. So you really want to be careful. Patients that have a lot of spine disease, they have higher rates of dislocations. If you malposition your implants, and we'll discuss what that means, you can also have a higher rate of dislocations. Repairing soft tissue in elective surgeries. When we do the approaches, we fix back the capsule and the external rotators in the posterior approach. When you're doing trauma surgery for hip fractures, a lot of times the capsule and everything is still intact, so it's a little bit harder anatomy, harder to discern what's what because there's a large hematoma and bleeding in the area due to the fracture. But if it's more subacute fractures, you can usually do the same kind of repair as you do in an elective hip replacements. So you can see here, this is an image of a dislocated hip. So if you fix the capsule, then the posterior approach has the same dislocation rate as the anterior approaches compared. Of course, in some countries, robotics is not available or different technologies, but where technology is available, the risks of dislocation have decreased tremendously with the use of technology. It's mainly because it assists in proper acetabular cup positioning in total hip. It has less of an effect on hemiarthroplasties for fractures, for example. But you can see here the capsular repair On the right, where you repair back the capsule and the short external rotators back to the greater trochanter. I personally do it with drill holes. I pass sutures into the capsule and external rotators. When I do my dissection, I don't separate the external rotators from the capsule. I take them off as one unit and then repair them back into the greater trochanter. So when you look at different instability in the hips, it can be because of malposition of that acetabular component when you do a total hip, and can be malposition of the femoral component. That means you didn't put the stem in anteversion, you put it in neutral or retroversion position, and then the greater trochanter impinges easily on the pelvis in the front and the hip pops out the back. If you have some abductor deficiency, any implant on implant impingement or bone on bone, and of course, long time wear of polyethylene and unclear etiologies. The polyethylene wears, which is that acetabular material, is kind of going away as the new polyethylenes have been in the market since the year 2000, more or less. So we have less and less patients that had total hips in the 90s. So let's talk about malposition, soft tissue, and impingement, as we did. So if you look at wounds, different signs of how wounds look when they don't heal. So some of the things we do is a lot of irrigation when we do these surgeries, putting antibiotics into the wound, making sure the patient gets antibiotics for a day after. And if you have a high risk patient, you can even give extended antibiotics if you think they're in fracture cases. But the biggest thing is antibiotics perioperative and a lot of irrigation and trying to keep the surgical time to a minimum. A lot of these cases can be done between an hour and two. When you start going beyond that, these surgeries, the risk of infection starts increasing a lot. So when we look at NYU data, surgical time, patients wait, and using negative pressure dressings if you have them, and younger surgeons or earlier in their career, these were kind of the risk factors that we found. We did find that some approaches that are more next to the groin or dirty areas have a higher rate of infection a little bit, or wound complication to be more accurate. So with the anterior approaches, as you can see in that picture on the right top, in patients with obesity, that skin fold, the pannus, falls exactly where the end of the wound is, and that causes a lot of wound problems. Not so much infections, but a lot of wound problems. If they're treated well, they can be resolved, but that's something to be aware of and thinking about your patient population and where you want to do the surgery in order to decrease the infections. Because compared to a lot of the complications, infections, if it becomes a deep periprosthetic infection, you have to go in there and most likely remove implants at one point if you can't get the infection under control. So if you're dealing with patients that are severely obese, think about the approach, think about how to deal with soft tissue, retracting them, and hemostasis, and really minimizing the trauma and obesity. We've shown from data from NYU that surgeons that operate a lot on obese patients and are used to it, their complications and outcome are similar to non-obese patients, but that's due to experience of the surgeon and the team, as well as the tools and instruments, that specialized instruments and tools for obese patients that we have. So those are important. So these are different things about thinking about to avoid infections. The betadine paints when you scrub and prep the patient. Remember that betadine has to dry. So if you just wash it and dry and remove it with a cloth, it's not going to do its work. You want to let the betadine dry. Different irrigations during the surgery, then dressings. And if you have infections, early infections, we can treat with irrigation debridement, where we open the wound, we irrigate. Sometimes we'll change parts that are easily exchangeable, mostly to be able to access better areas, but also to remove if any biofilm is starting to form on the head or a polyethylene liner that are easily exchangeable. The implants have been cemented in the early infections we tend to keep and try and see if by doing this irrigation debridement, we can get the infection under control. So early function, it's very important. We let our patients ambulate immediately after these surgeries. Currently in the US and NYU, about 60+% of our patients go home on the day of surgery after hip and knee replacements, and 99% leave by the next day. So getting our patients moving in the first few weeks is extremely important. The recovery, overall health, and function is better. No big differences between the approaches at this time. All patients can go home. There's no advantage to any approach over the other. While doing that, the differences are non-clinically significant. Last thing is periprosthetic fracture. Looking at them, characteristics of the femur fracture, complications. So the anterior approaches have a higher rate of intraoperative femoral fractures due to the little bit more complexity and skill needed for the anterior approach. But more experienced surgeons also don't have a lot of those fractures. And of course, use of cemented implants decrease that. So component position. The classic teaching was our acetabular cups have to be in 40 degrees of abduction, 20 degrees of anaversion, or between 5 and 15, even the Llewellyn zone. But we've shown that even when we place these cups in that ideal position, and you can see here the square, this is a paper by Abdel, there's a lot of dislocations within that area. So the safe zone, as we learn more, has to do with how the patient walks, stands, and sit. For example, this is a patient that has spine fusion. You can see the hardware up there in the spine, and you can see the difference between when the patient is standing and sitting, and you can see how that affects the cup position. The cup becomes more anaverted as the pelvis is extended and more anaverted, more open, and that can lead to a posterior impingement and anterior dislocation, or patients like the image on the left that are kind of fixed in a standing position. When they sit down, their pelvis doesn't move, and then they can have an anterior impingement and posterior dislocation. This is a little bit more advanced hip replacement. There's online a lot of information about the hip spine, how to do these measurement of sacral slope and anterior pelvic plane deformities. This is the natural movement of our pelvis. You can see the pelvis moves when we stand and sit, and logically this will move the cup into a different position and protect from posterior dislocation. But when the pelvis doesn't move like this because you have spine fusion or just older age, you have to position the implants differently. If anybody has questions on this, we have a lot of talks online to things, or can also reach out to me. I'm happy to explain. Dual mobility, if you have access, these are constructs that allow larger heads. The larger the head, this decreases the risk of dislocation, because when the implant impinges, the head has to jump out of the cup. So the larger the head, the larger is the diameter, the radius that needs to move in order for the head to come out is larger. So even though the head is subluxating within its cup, it may not dislocate because there's such a large, what we call jump distance for that head to jump out. And you can see here an example. The head is impinging, but that head is not coming out. It has to get all the way to that edge in order to pop out. And a smaller head has less motion that needs to do that. And at dual mobility, you can see even a larger head needs even more range of motion to come out. So the impingement-free range of motion is when the implant touches the edge of the cup, or the greater trochanter hits the bony surface. That's the range of motion until you have that lever arm that wants to pull out a head outside. And the larger the head, the larger the jump distance, that gives you that benefit. If you have, sometimes in hemiarthroplasties, they have a head within a head, like a dual mobility. So that sometimes the inner head can separate from the outer head. That's called an intraprosthetic dislocation. That happens more commonly when trying to reduce from a dislocated dual mobility, or in hemiarthroplasty, I have not encountered that more than once. But in dual mobility femoral heads, it can happen when you try to reduce it. It's like a beer bottle. It gets caught on the edge of the cup, and that outer plastic that you can see here in the top right gets popped out from the inner head that's inside. So dual mobility usage has been increased in the United States, especially in revision cases, a lot. If you have options, when you do hip replacements, a larger head, use a larger head. All the data point to less dislocation and no other downsides for it. When you do hemiarthroplasty, you can't really play. There's one appropriate head for that. That's a native acetabulum. That's important. So larger jump distance. The cons for large heads have not stressed out anymore with modern things. So less dislocations with large heads. So the important thing the most important thing is where you position your implants. Just using different bearing and different head sizes doesn't solve that. When you're doing hip replacement and you're doing acetabular cup, You want to make sure that acetabulum fits inside. You want to make sure you didn't ream out the walls, or you don't have soft tissue impinge in order to get that acetabular cup to be in there. If you need, sometimes you can add screws if you have them available. For your primary cases and more complex revisions, we use a lot of screws to give that initial fixation. But as long as the bone is adjacent and touching the back of that acetabular cups, the materials now are extremely well, and you get good bone healing. Let's talk about cement. As I said, cement helps a lot of different options. So cement on the femoral side helps you use different sizes. You don't have to make them perfect to the bone, right? We have the cement mantle between the implant and the bone, so you can have less options on your sizes or be less accurate, or you don't have to risk a fracture by really going to that press fit in the end. So this is data from the American Joint Registry, looking at a tremendous amount of cases and seeing when we cement, the revision risk for periprosthetic fractures and all-cause revision goes down. So we can see the image on the left. You have a press-fit acetabular cup and a cemented stem. The cement fills the canal, so you can have a difference in sizes, and the risk of fracture is much lower because you're not trying to fix a press-fit stem into the femur. Then the patient with weight bearing cannot cause fractures that easily with a cemented versus a press fit. So the reason why cement has become less popular in North America is mostly because of time. It's much quicker to not use cement. The new stem options are easy to put in without cement, so the surgeons favor that, but there's still countries in the world where cement is dominant. And even though a lot of places shifted to non-cemented stems, the literature and the data show that cemented stems do as good, if not even better, than press-fit stems. So it was not a reason because the cemented stems did not work well. It was just another option, and that was quicker, and surgeons always prefer to be quicker. So just remember, there's different cemented stems, taper slips, the smooth ones, and composite beam. Those are the ones that are not shiny and polished and usually have a collar. So different techniques how to use. I think the collared ones are easier to use than the taper slip. So if you have the different options, the one on the left is the taper slipped. The one on the right is the beam collared one. Cement techniques, there's a lot of different ways how to use cement, what we call first generation, second, third, fourth generation. Mostly depends on the technique of using the cement. So the first generation was just, you take cement, you mix in a bowl, you put it in your hand, and you just stick it down the canal. The second was that we start having a cement restrictor. That means you use a piece of bone or a piece of plastic that comes, and you put it just below where you want the cement to end. And then you use a cement gun, and before that, you prepare the canal with irrigation, you clear it, and then you pressurize the cement in. The restrictor stops the cement from going all down the femur, and you get a better cement pressurization. The third is using vacuum to mix the cement. As we discussed, pressurization and post-lavage is the part of the preparation to prepare the canal before. And the last is third generation with retrograde filling, just meaning you're filling the canal. I think one of the important things when you use the beam with collared stem is make sure you coat the stem with cement as well as filling and pressurizing the canal, because the place you do not want to have blood or tissue is between the implant and the cement in the beam collar type stem, because that can make the stem being loose and losing its bonding with the cement. So cement timing, you want to be familiar with how fast a specific cement you have hardens. You don't want to get stuck with cement that's starting to harden the canal before you put the stem in there. Each brand of cement has a different time to harden. So in the beginning you mix, so it's usually depending on the cement, so it's can be anywhere from half a minute to a minute and a half of mixing. Again, depending on the cement, so make sure you're aware of it. If you've never used this cement, I recommend first time just have a packet and use it outside of the OR and do the procedure and see how fast everything goes. It's better to be early and have the cement still liquid and messy a little bit than be late and have a stem that you started pushing down the canal and get stuck. Because then you're going to have to somehow remove it and remove cement, and that becomes extremely difficult. So we said the mixing, then the next phase is just waiting it to become the consistency that you're ready for it. And then around anywhere between 2.5 to 4.5 minutes, depending on the type of cement, you start filling. You can see here filling with the gun. And when you fill the canal, you're filling it like a soft served ice cream. You put the thing all the way in, and you start putting cement and move it out as the cement comes. And it's more of a feel because you can't really see it. And you don't want to have that big guide all the way down the canal filled with cement. You're slowly bringing it out as you're pushing cement. The thumb is there to give pressure. So you're pressurizing the cement so the cement doesn't get pushed out. So it gets pushed into the cancellous bone. And then the second phase, here you see pressurizing with the thumb, he's pushing it in. And now the third part is using the gun after breaking the top part. And again, doing a few pushes of cement, trying to pressurize it even more. At that point, getting the stem ready. As I said, I don't do what's on the picture. I put cement around the stem to make sure I don't get any blood between the cement and the implant. So my stem is also coated with a thin layer of cement, and then pushing it in and holding it in place until the cement is hard and clearing, of course, any excess cement from around there. And anywhere between 10 minutes and 14 minutes, the stem should be hard. So bearing surfaces, I don't think we have to go on that. These are different surfaces, but I think the most common now is either cobalt chrome heads on polyethylene or ceramic on polyethylene. All of the other options are not commonly used anymore or actually not in the market, like metal on metal heads. Ceramic on ceramic is also going away. So I would say cobalt chrome on polyethylene, or if you have the option of ceramic or oxinium on polyethylene will be my preferred options, like this in the picture. Any questions?